Good afternoon, everyone. Thank you for joining us today. We're just going to let a couple more people come in before we get started. My name is Cesar Velasco, and I will be your guest moderator for this session. I want to welcome everyone to the 2024 Engagement Lounge webinar series presented by the Association of Neurovascular Clinicians. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families, because stroke patients deserve nothing less. For more information about ANVC, please go to www.anvc.org and become a member today. We do have a few housekeeping items before we begin today's presentation. This session will be recorded and made available in the members only section of our ANVC website. However, only viewers who attend this live session in its entirety will receive one continuing education hour. Viewers who attend this live session will receive an evaluation from Arizona State University. After completing and submitting this evaluation, participating viewers will receive a continuing education certificate, but you must attend the entire live session to receive this credit. Please feel free to enter any comments or questions into the chat throughout this presentation, and at the very end, we will review questions with our guest speaker. And now it gives me great pleasure to introduce you to Dr. Brandon Baughman. Dr. Brandon Baughman is a board-certified neuropsychologist. His clinical practice is housed within the Sims Murphy Neurologic and Spine Institute, a multidisciplinary clinical neuroscience program in Memphis, Tennessee. Dr. Baughman's practice is lifespan-oriented, including patients from the ages of 5 to 99 plus, who present with a variety of neurological injuries and neurodevelopmental disorders. Dr. Baughman also holds faculty appointments in the departments of neurology and neurosurgery at the University of Tennessee College of Medicine. His research interests include the assessment of neuropsychological outcomes to predict broader functional outcomes following stroke, TBI, and primary central nervous system tumors. When he is not at work, he spends his time chasing after his wife and 3 kids and a Labrador retriever. I give you Dr. Brandon Baughman. Welcome, sir.
Thank you, Cesar, and thank you for everybody for joining today. I really appreciate the leadership team at ANVC for allowing me to talk with you today. And the focus of the talk is about depression after stroke. As Cesar mentioned, I'm based here in Memphis, Tennessee. We are the belt buckle of the stroke belt, and so we have a high population of neurovascular patients here. Many of these are referred to me through my physician colleagues in clinic and in other clinics in the community with a variety of types of stroke. And one of the key pieces of the neuropsychological evaluation is to assess what is happening emotionally in these patients, because it can make a big difference in terms of long-term outcomes and quality of life. Now, I will, for full disclosure, say that as a neuropsychologist, a bulk of my practice is spent in consultation and assessment. While my degree is in clinical psychology and I've been trained to do therapy, very little of my practice is actually providing psychotherapy. And my scope of practice here in Tennessee does not include prescription. So I do not prescribe psychotropic medications and I don't provide psychotherapy. However, it's important to understand the role of these in terms of managing post-stroke depression, as well as providing some guidance to the patients who are coming through the clinic and how to partner with other folks in the community to provide effective care. As far as disclosures, I do receive some consultation fees from Balt and Medtronic. However, I'm not going to be discussing any commercial products or any studies in this presentation. So as far as post-stroke depression is concerned, we don't really have a good understanding of what the true or exact pathophysiology is. We think about it as being multifactorial. We think that it's this combination of various ischemic-induced neurobiological changes in this context of psychosocial distress. So experiencing the emotional reaction to going through something that's very serious and life-threatening. From a biology standpoint, there's questions as to whether or not the emergence of post-stroke depression might be a function of genetics, or is it, again, the direct, is it a causal outcome in ischemia? Is it related to neurotropic factor alterations? I'm sorry. Is it related to dysfunction in monoaminergic pathways in the brain? There's several lines of evidence that suggest that there's a neuroinflammatory tie-in with post-stroke depression, as well as the relationship between activation of the HPA axis in folks that have ischemic stroke, or whether it's a function of impairment in the adaptive response, so neurogenesis secondary to stroke, within this overall background of altered energy metabolism that you can see following stroke. We know that it's not an uncommon outcome. About general estimates put it at about 30% of survivors of stroke will develop depression. Generally speaking, the onset of depression symptoms start shortly after the stroke. It can be immediately or maybe up to a week out. While many of these patients may recover within, several weeks, there's not an unsubstantial number of these cases or patients that will continue to have symptoms even months, if not years, following the event. And unfortunately, post-stroke depression can be hard to identify in some cases, and it may be overlooked as being related to something else. It may be seen as a sign of normal aging, or it may be seen as, for example, some of the vegetative symptoms of depression may be chalked up to the neurologic effects of stroke. I did want to share a couple of slides, just looking at more of the epidemiology and natural history of depression. So these are a couple of studies that have been published and that are frequently cited. There's some great guideline documents published by the American Heart Association, American Stroke Association, and these are a couple of studies that are published there. In the first study by Irby et al., they reviewed 50 studies of post-stroke depression, and what they found was, again, about 30% of people will develop symptoms of PSD after stroke. The cumulative incidence within 5 years of stroke was about 39 to 52%. And recovery in this group ranged from 15% up to 57% within the first year of having a stroke. Now, in this more recent study by Liu et al., they reviewed 77 studies. The pool prevalence here was still generally in line with other estimates of 27%. Now, when they looked at the studies that based PSD diagnoses on structured interviews versus rating scales, there was a slightly higher rate when you were assessing PSD based on questionnaires as opposed to the interview. And we'll circle back when I talk about some of the ways to assess that. What they found, though, was that in the groups of patients that develop post-stroke depression within 3 months of their stroke, about 53% continue to have longer-term or persistent depression, whereas about 44% ended up recovering. Now, when you look at cumulative incidence at 1 year, about 38% were still symptomatic. And if you look within that group, about 71% of the people who were still symptomatic at a year had developed their depression symptoms relatively soon after the stroke. So they set a cutoff at about 3 months. Now, the same author group has published some additional work, and their population was generated from the South London Stroke Registry. This is a group of about 6,500 subjects. And in the study, they were looking at the Hospital Anxiety and Depression Scale, which is one of the screening measures that's frequently cited. And they had within this group long-term follow-up. So they were having patients come back every year, and they actually reported on 18-year follow-up data, which makes me jealous of the UK and Europe, where they can do these great population-based studies that's harder to do here in the United States. They actually had about 150 patients that they had 18-year follow-up data on. And what they found in their follow-up was, of those patients who developed depression within 3 months, and then recovered, about 66% of those patients ended up having a recurrence of their depression within 5 years. They also found that those patients with more severe depressive symptoms tended to have a slower recovery rate. Furthermore, those with more severe depression showed a higher percentage of recurrence at 1 year compared to those with more mild depression. So their conclusion was that that long-term depressive status, you generally can establish that by 5 years, while the natural history of patients that developed early versus later onset depression was meaningful in some cases. It wasn't as meaningful as looking at the severity of depression in terms of predicting longer-term outcomes. So again, those with more severe depression tend to have longer symptoms, more persistent symptoms, and when they became asymptomatic, they generally had a quicker recurrence compared to those patients that had more mild symptoms of depression. Now, one of the questions in these studies is generalizability, especially with these long-term follow-ups, because these are based on patients that are still alive. And so you have to ask the question of whether or not there was some sample restriction here, because you're getting maybe the more milder stroke patients. So if you're excluding a population that had a more severe stroke, there's some data, and I'll talk about that here in a second, where the more significant of a stroke that you have, the greater the possibility that you might have more severe depression. Nonetheless, though, we know, again, generally the estimate for post-stroke depression, 30%, keep that number in mind. Several patients can recover and become asymptomatic. You have a better chance of recovering if your depression symptoms are mild. Those with more severe symptoms tend to have longer recovery, and they tend to recur more quickly. There's also been work looking at whether or not lesion laterality or location can predict who might develop post-stroke depression. In this first study, and I'm going to butcher the name, Jurathny and Sales in 2021, they reviewed 25 studies, and they found in a majority of them, there was no significant associations with side of the brain and whether or not those patients would develop post-stroke depression. They did show in 6 of 25 studies reviewed that people with left-sided lesions tended to have greater rates of post-stroke depression. Now, some of this question of laterality harkens back to some of the early papers from the 80s and the 90s. When I was in grad school, I remember my mentor always talking about, well, you know, folks that had left hemisphere lesions, they tend to look more depressed and apathetic, as opposed to folks with right hemispheric lesions tend to look more aggressive or irritable or even manic in some cases. So that's kind of what I grew up with professionally, if you will. But we now see that studies don't really suggest that. Now, if you go back again, you know, one of the prevailing thoughts about hemispheric lateralization and emotion was this idea that the right hemisphere of the brain tends to have a perception of the world being negative, whereas the left hemisphere tends to perceive the world in a more positive light. So this then evolved into this dominance idea and this idea of contralateral release. So in other words, if you lesion the dominant hemisphere, so the left in most cases, this somehow dampens or releases the inhibitory role on the non-dominant hemisphere, which then allows depression to manifest. Again, you know, that idea has not really held up over time, but for several years, that was kind of the idea why some people would develop depression and not. Now, it's a slightly different story when we talk about specific localization. So in this same review, the authors found that there was no significant association with post-stroke depression and location of the lesion, not full laterality. And that was in about a third of the studies. Of the remaining 2/3, what they found is that those folks that tended to have more anterior, so think frontal subcortical pathways and regions, those patients tended to have greater rates of post-stroke depression. They also reviewed data showing that imaging studies, which showed that for the patients that had reduced volumes in the frontal cortex, as well as reduced volume in the basal ganglia, that was also associated with post-stroke depression. And then in some PET studies, they've also found that reductions in metabolisms in certain regions, it can be related to post-stroke depression. So that included the dorsolateral prefrontal cortex, the medial PFC, the basal ganglia, and the cingulate cortex. So again, while we don't see the consistency with laterality broadly, we do see that there are some patients that can be more vulnerable to post-stroke depression, especially in those anterior regions of the brain. Now, when we talk about post-stroke depressions, what are some of the signs and the symptoms? So, depression oftentimes gets referred to very broadly. So depression being a sadness, being a mood issue. Sometimes we see the term depression and anhedonia get conflated. They're two different concepts, though. So they go hand in hand frequently, but they're still different. They're different. They're operationalized differently. So if a depression or a depressed mood is that subjective feeling of sadness or feeling blue or feeling down, anhedonia is really more of a loss of pleasure. So a person who might be depressed, let's say they really love watching Netflix on Saturday night and they get given the opportunity to watch Netflix and they're like, I just don't really, it's not really giving me that same sense of happiness doing this activity. So this loss of pleasure is one of the core manifestations in depression. Some of the other signs and symptoms could be fatigue, could be apathy, amotivation, having trouble getting started on things that you need to do. You can see signs of depression via social withdrawal, just wanting to be by yourself. You can see changes in psychomotor functioning. So I frequently hear from patients with depression how it feels like someone just poured molasses in my brain and everything just requires effort. It's just moving in slow motion. On the flip side of that, you also have folks that will report more psychomotor agitation, where they kind of feel restless as a part of the depression. Cognitive impairment, which as a neuropsychologist, we kind of live in this world of cognitive assessment, but cognitive impairment is frequently seen in depression. Talk about that a little bit more here shortly. You can see changes in sleep behavior, either insomnia, difficulty falling asleep, staying asleep, waking early, or hypersomnia, where all you want to do is sleep all the time. Now, irritability frequently as a negative mood state is associated with anxiety, but it's not uncommon for people who feel subjectively sad to also have experiences of being irritable, having low frustration tolerance. There's also appetite changes where sometimes people will lose their appetite or they'll just want to eat all the time. Then you have these set of symptoms that are more self-evaluative, kind of how we organize our thoughts about ourselves. So it's not uncommon for people who become depressed to feel hopeless or to feel helpless or to feel worthless in some way. Frequently, I hear patients, especially the younger ones who are still working, maybe have families where they feel guilty about being depressed because they feel like they should be doing something. I also see it. Not only do we live in the stroke belt here in Memphis, but we're in the Bible Belt. So a lot of my patients are very strongly affiliated with a religious institution, and their faith is very important. So I hear all the time, well, I feel guilty for feeling depressed because I really shouldn't feel depressed. I go to church, I have God in my life. And so why am I feeling depressed? And unfortunately, that guilt can then circle back and reinforce the depression. And in some cases, people can develop suicidal ideation. So again, the signs and symptoms of post-stroke depression are quite varied, and you don't necessarily need to see all of these to diagnose post-stroke depression. You can see any number of combinations. Now, as far as assessment is concerned, you have basically two strategies. You have kind of semi-structured psychiatric interviews. So examples of these would be the structured clinical interview for depression, the SCID. The DISH is the depression interview and structured Hamilton scale. This is designed more for patients with medical conditions. Then you have the Mini Plus, which is a neuropsychiatric interview. Then you have all these screening tools. Now, the big difference with semi-structured psychiatric interview is time. Now, if you were to do a full Mini Plus where it takes you through all the different modules within the DSM, it might take you 30, 45 minutes, an hour, and that's oftentimes not feasible. Now, you can do specific modules. Personally, in my practice, because I tend to see a higher volume of patients, I will have them complete a screening tool on the front end. I'll review the screening tool, and then I will follow up them when I'm doing my interview with the patient or their family on some of the things that might have come out from the screening instruments. So you've got a lot of options for screening tools. So the Beck Depression Inventory, the Hamilton, the HADS. For older patients, the Geriatric Depression Scale, the Montgomery-Åsberg Depression Scale, the PHQ-2, PHQ-9. All of these differ in terms of how brief they might be as well as coverage. I think for stroke, one of the things that I do like about the Beck and the Hamilton is they do a slightly better job teasing out some of the vegetative or somatic symptoms of depression than some of the other scales. What we've been using for the past couple of years in clinic, and this is not just for my stroke patients, but for all of my neurologic populations, is I PROMIS scales. So the NIH PROMIS scales, and specifically the Neuro Quality of Life. I've put the link in it for those that are interested in checking those out. So I think the PROMIS is a step forward. It's very psychometrically sound. It's stable. It's reliable. And I like the fact that it provides a broader assessment of not only mental health, but you have scales that assess physical and social health functioning. There's also some cognitive, kind of perceived cognitive dysfunction questions as well. They're very flexible, and they also they generate a standard metric. So based on responses, you can generate T-scores, which are comparable metrics across these different scales, as opposed to a lot of other scales. You have different amounts of points for each one, and different ones have different cut points. When you have a standardized metric, it allows for a common communication between the scales, which I personally find helpful in terms of better understanding where they're at across these multiple dimensions. So you have a lot of different options here. When it comes to risk factors, we know that people with post-stroke depression, or the emergence of post-stroke depression is higher in people that have premorbid history of anxiety, depression. That seems to be fairly intuitive. For those that have greater physical disability, cognitive morbidity, they tend to have greater rates of PSD. People with comorbid anxiety. So frequently anxiety and mood disorders co-occur, and the presence of a concurrent anxiety disorder increases the chance of having a mood disorder as well. I mentioned this earlier. So when you look at lesion volume, so larger territory strokes, there's some data suggesting that those individuals are at risk of having higher rates of PSD, and the symptoms tend to be more severe. We also know that having a prior history of a stroke can also increase risk. There's some sex differences that have been found in the literature, with females more than males being at risk for developing PSD, as well as older individuals compared to younger individuals. And finally, psychosocial and caregiver support. So people that lack that support in their lives as they're recovering from stroke are at risk for developing PSD. There's also some indication where you're looking at whether or not the post-stroke depression will become persistent and last longer. These have been, in italics, there are some of the factors that have been associated. So if you had lower levels of pre-stroke socialization and social connectedness, that has predicted persistence. Again, the more severe the stroke is, that is associated with persistence. And then also lower level of premorbid baseline. So this gets into that concept of cognitive reserve capacity. So basically how much brain horsepower that we kind of develop over the lifespan. And so people with higher levels of reserve are able to absorb neurologic hits and come out of the other side a little bit more effectively. And so people with lower reserve capacities tend to develop more cognitive and emotional problems, and especially those problems that tend to last for a longer period of time. Now, diagnostic criteria for depression. So if you look at the DSM, I'm going to walk through a few of these fairly quickly. But within the depressive disorder category, you've got major depressive disorder, you've got persistent depressive disorder, what we used to call dysthymia. You've got depressive disorder due to another medical condition, and then a few other subtypes. So premenstrual dysphoric disorder, substance or medication-induced depressive disorder. And then you have these other categories of other specified or unspecified, where people may have different symptoms, but they don't really fit anywhere else. One of the most common forms of depression would be major depressive disorder. Now, this is characterized by a person who will develop 5 or more of the following symptoms that are all present consistently within a 2-week period. So you've got that subjectively depressed mood or anhedonia. You have to have one or both of those to meet criteria for major depression, plus some additional symptoms. Criteria B is you have to have some impairment as a result of your depression. Now, criteria C is interesting, and I think this will be important when it comes to what diagnostic codes you use when you might be diagnosing PSD in a patient. So major depressive disorder specifically says if you develop depression from the physiological effects of a substance or another medical condition, which stroke falls into that category, you shouldn't be diagnosing major depressive disorder. The other criteria, developing depression symptoms cannot be accounted for by becoming psychotic or by being manic or hypomanic. So again, I see this frequently in some providers where a patient will have a stroke. They'll look like a patient with major depressive disorder, so the code for that. But there's that criteria C that really suggests that we shouldn't be using that as a code for our patients. Same thing for dysthymia. Dysthymia, if any of you remember Winnie the Pooh back in the day, you've got Eeyore, who is the sad donkey. Eeyore is the perfect example for someone who's dysthymic, who's just kind of sad all the time. Now, not going through major depressive disorders that are really cyclical. People with dysthymia just kind of stay under the surface all the time. So these folks, the criteria is you have to have symptoms of depression continuously for 2 or more years. And within that 2-year period of time, the symptoms, a patient cannot become euthymic for more than 2 months. If they do, they no longer fit into this category of dysthymia. A lot of the same criteria apply to major depression, including criterion G, which again, you wouldn't diagnose dysthymia in someone who developed these symptoms because of a medical condition like stroke. Now, there are some people that can have major depression and dysthymia. That's what we refer to as double depression. Those folks tend to have a lot more difficulty with life in general. Oftentimes, they become refractory to medications for depression. They become refractory to psychotherapy. And now psychiatrists have other options. So things like ketamine might be used in some of these folks, neuromodulation like ECT or transcranial magnetic stimulation as an adjunct to medicine and therapy. But the doubly depressed folks really have a rough time. But again, dysthymia would not be the best option for diagnosing post-stroke depression. In my opinion, this is what you should be using. This is what I use. So depressive disorder due to another general medical condition. So criterion A, you have prominent and persistent depression or anhedonia that predominates the clinical picture. It is due to the pathophysiological consequence of the medical condition. It's not accounted for by another mental condition. It's not related to delirium. And this distress does contribute to functional difficulties. Now, you can have within this category specifiers. So there are some people with this that have depressive features. Sometimes it can look like they have a major depressive episode or have some mixed features. This, in my opinion, is the more appropriate diagnostic category or classification or code to use in our PSD patients. The other thing that I will sometimes see in patients is that they will be diagnosed with one of these trauma or stress related disorders. Most commonly what I see is an adjustment disorder. So an adjustment disorder is where you develop emotional or behavioral symptoms in response to some stressor, and the symptoms have to start within 3 months of that stressor. Some have conceptualized, well, isn't stroke a stressor? No, what they mean by stressors here are psychosocial stressors: a loss of a relationship, a death in the family, losing your job, going through a natural disaster. So I have good friends in Western North Carolina right now who have been hit by the hurricane, and if they are developing anxiety and depression symptoms because of that, that's where it would be appropriate to diagnose an adjustment disorder, not in the context of a stroke. So again, criteria C there talks about, I'm sorry, criteria C is another mental health disorder. So they don't really specify you can't have this because of a general medical condition. But if you read the text of the DSM, they talk about these stressors being more psychosocial. Now, some people have suggested, well, isn't having a stroke a form of a traumatic experience? We can have a whole nother talk on that specifically. There are certainly experiences that we have in our lives that are potentially traumatic experiences. But when we talk about psychological trauma and we think about in the context of PTSD, people who go through that have a stroke frequently do not fit the conceptualization and the operational definition of developing post-traumatic stress disorder. So again, PTSD is one of these trauma and stress related disorders. Oftentimes it may start with an acute stress disorder and adjustment, but if it continues past 6 months, then you start seeing conditions like PTSD diagnosed. I don't believe that that is an appropriate way to capture some of the emotional changes after a stroke. Because I'm a neuropsychologist, I would be remiss not to talk about the neuropsychological profile that we see in patients with stroke. Now, typically speaking, the persisting neurocognitive phenotype, we generally talk about it as subcortical, right? That's not to say you can't develop aphasia syndromes or agnosia syndromes with cortical lesions, but in general, if those are not present, or maybe they were present and it's recovered, what we tend to see in clinic, especially for patients that are further out, is this subcortical pattern, which presents as slow information processing speed, attention and concentration deficits, and executive function. We typically don't see people with these rapidly amnestic profiles like you might see in an Alzheimer's patient. We don't see patients with real severe visual spatial loss or language deficits. Now, sometimes the location and the vessel can contribute, but it's not perfectly predictive. In some meta-analyses, they show that 40% of people may experience cognitive impairments within 2 to 6 months. And oftentimes these cognitive impairments don't hit the level of dementia. So they can have these mild neurocognitive disorders, which still can be interfering, but they may not be severe enough where we would characterize it as a vascular dementia. Stroke subtype can predict what these neuropsychological profiles look like. So for example, an older adult with ischemic stroke may look very different than my younger patient who's had a subarachnoid hemorrhage due to a ruptured aneurysm. So stroke subtype can affect that. In studies that have looked at neuropsychological changes, unfortunately, there's a lot of methodological heterogeneity in how they identify impairment. One of the things that's frequently seen is a majority of studies that have looked at cognition are relying on global screeners. And again, this may be a whole nother talk, but when you're using something like a mini mental status exam or a MOCA or a SLUMS, these relatively brief cognitive assessments, they tend to lose sensitivity and specificity, especially in patients that are having more mild or moderate types of deficits. They're pretty good about picking up dementia when someone's got, a pretty significant or a profound cognitive disorder, but they lose that sensitivity and specificity on the younger side. I bring up the neuropsychological profile because that subcortical profile that we see generally in vascular patients, that also overlaps with what we can see in patients who've never had a stroke, but who might have unipolar depression, right? So one of the signs and symptoms that patients who are depressed will frequently have cognitive impairment. This is unfortunately what their cognitive impairment looks like. So it becomes a challenge when you're trying to differentiate, well, this person's saying they're really dysexecutive, they can't focus, they're slow. How much of this is stroke? How much of this is depression? And so getting a clear understanding that oftentimes requires a deeper dive and potentially a referral to neuropsychological testing to really kind of understand what's driving that, because that can then impact, as you're getting a person back into their normal routine in everyday life, how you approach managing those cognitive issues can differ based on where they're coming from. Okay. When it comes to long-term outcomes from related to post-stroke depression, is that it's associated with poor functional outcomes after stroke. In this first study, systematic review, and there's a total of 8 studies. These are prospective. What we found, or not what we found, what the authors found was that depression corresponded with negative consequences. They had more difficulties for the folks that were depressed returning to work. And that people with post-stroke depression had increased risk of cognitive impairment. All right, we're back online. Also, in that same review, they found that post-stroke depression was actually related to premature mortality in these patients. In this next review, that was published in the International Journal of Stroke in 2014. So this was a review of 14 studies, about 4,500 patients. What they found is that post-stroke depression interfered with rehabilitation goals and progress. Post-stroke depression consistently contributed to adverse outcomes, some of the same outcomes that were noted in the previous paper. So returning to work, functioning at home. They also found, again, that post-stroke depression was associated with higher mortality, poor quality of life, and it was associated with a greater need for institutional care after stroke. So again, we know that the presence of post-stroke depression can negatively impact long-term outcomes. Now, when it comes to management, generally speaking, this is kind of where we're at. So you have pharmacologic options, you have psychotherapy or psychosocial interventions, you've got support groups, psychosocial support, as well as broader support groups. And then there's been several studies that have looked at exercise as its own intervention for post-stroke depression. Now, with regard to antidepressants, they have looked at the utility of antidepressants in different ways. So looking at whether an antidepressant could manage functional impairment that was related, using antidepressants to actually treat the post-stroke depression, managing stroke outcomes, not just functional impairment, but broader outcomes in patients with depression. And then finally, using antidepressants to prevent post-stroke depression. They've also looked at these as potential mechanisms to help outcomes even in stroke patients who don't have post-stroke depression. Generally speaking, the randomized clinical trials have been limited. Oftentimes they're confounded. There's a lot of heterogeneity in terms of the methodology for these studies. So for example, how different studies are screening and diagnosing PSD is all over the map. Some you'll see semi-structured interviews, some you'll see screening measures, what specific diagnostic codes that they're using. You see some of those DSM codes that I mentioned before. In other words, you don't see anything. They're plagued by small sample sizes in many cases, shorter follow-up. So you might see a treatment that is extended and you're looking at outcomes at 3 or 6 months, maybe a year, but not beyond that. And then again, how you're operationalizing improvement in the depression is quite varied. The other thing that limits these studies is that most trials are excluding patients with more severe stroke, whether that's due to there being a language problem like aphasia or cognitive impairment or some other psychiatric confounds. So there's some questions as to whether or not these studies are generalizable to all patients with post-stroke depression. Here's an example of a couple of papers that have looked at treating depression following stroke. So the first is a Cochrane review. This is from 2008. So 16 trials, about 1,600 subjects. They were able to review 13 different pharmaceutical agents as well as 4 trials of psychotherapy. What they found was that there was a small but significant effect on pharmacotherapy on treating depression and reducing depression symptoms. In their psychotherapy review, they did not find that psychotherapy was as effective or effective at all in managing depression. In this paper, this was the affinity trial. So this was looking at fluoxetine to try to manage depression during stroke recovery. So this was a trial that involved about 1,200 patients. They received 20 milligrams of fluoxetine over 26 weeks. And what they found is it didn't really help all that well with anything. We also have this paper. This is from the Journal of American Heart Association. So they looked at the safety and efficacy of SSRIs in improving post-stroke recovery. So this is a more recent meta-analysis published in 2022. So here they reviewed 44 trials, about 16,000 patients. They reviewed only placebo-controlled studies, and they were reporting SSRI effects on post-stroke depression. But they also looked at other outcomes like anxiety, disability, function. And what they found is that SSRIs did, in fact, have a significant effect on preventing depression. And they were looking at that based on changes in the HAM-D score. There were also some benefits to anxiety, motor abilities, and cognition. However, they didn't find that using antidepressants had an effect on the level of disability in these patients. They did show that there was an increased risk of seizures for some of these patients, but it did not interfere with GI symptoms or cause bleeding. They did a sub-analysis here to look at whether there were specific agents that were more effective. And in their review, they actually showed that Celexa was more effective than fluoxetine in managing outcomes in PSD. All right, so this was a study looking at another meta-analysis, and this was a network meta-analysis to investigate not only pharmacological but non-pharmacological interventions. Primary outcome, like many of these studies of the HAM-D score, they had 23 randomized trials that they were able to identify. About 1,500 subjects were included. There were 9 different interventions, and this was kind of the level of effectiveness. So what they found is the norepinephrine drugs were the best, followed by tricyclics, followed by this combination of using psychotherapy and medication, followed by the SSRIs, followed by control, which is interesting because generally speaking, what I'm seeing in clinic is a lot of the physician providers are prescribing SSRIs as opposed to some of these other medications. However, this trial would suggest that maybe there are some other options that could be more effective. They also looked at neuromodulation. So they looked at transcranial magnetic stimulation, and they showed that that could also be used as an adjunct to medication and could be of benefit for post-stroke depression. Now, what about psychotherapy? Unfortunately, there's even less methodologically sound data. Here's a couple of examples of different studies that have looked at different psychosocial interventions. In summary, what they found was that there is some evidence for brief psychosocial interventions to be useful and effective in the treatment of depression. Now, whether or not you needed to have antidepressant medication to see the same benefit with psychosocial intervention was not established. And in many of these, we didn't have good clinical contrast groups or placebo controls. But we do have some options. So the CALM trial, again, this was behavioral therapy given over 3 months. In the Living Well study, there were 2 different parts. This is a psychosocial intervention. And it did show that it can improve symptoms. One of the things I was curious about, so within the cognitive behavioral therapy, the third wave of cognitive behavioral therapy, very popular for folks that are doing, for psychologists or licensed professional counselors, social workers that do therapy. So I was curious to see if there was any ACT studies out there. And this is the one trial I was able to find that was published in 2022. The difference between acceptance and commitment therapy compared to previous iterations of cognitive behavioral therapy is the idea of what the target is. So in cognitive behavioral therapy, the idea is that we have these thoughts, our thoughts affect our emotions, and our emotions affect our behavior. Oftentimes in people who are depressed or anxious, they will have these automatic negative thoughts that they seeing the emotional effect that it emotional state, it tends to drive what you're doing behaviorally. And so the idea control that thought reported when they're doing kind of traditional CBT is that they end up getting frustrated because they can't control the negative thought. So it's almost like, all right, I know I'm having to control it and shoving. The difference with acceptance and commitment therapy, the kind of holy grail for mental wellness is psychological flexibility. So it's have some kind of we're human beings, we switch emotions a lot. So the idea with ACT is to understand when I get stuck with this negative emotion, I can, rather than thinking about how I can push it out and get it away, I accept it. I commit to some targeted action to try to let it move out of me. And there's different, I'm not an ACT expert, but the idea is we can use these different strategies to kind of let those emotions keep moving. And so I was curious to see whether that was done in a stroke population. And this is one example of study. So they had 104 patients with ischemic stroke. They were randomized into an ACT group versus a usual care group. They received 5 sessions, about an hour long of ACT, and they looked at several different outcomes. So they had NIH stroke data, they had a Barthel index data, and they used the HAM-D to measure depression response. They also stratified patients into mild and moderate stroke groups based on the NIH stroke scale. And what they found was that the participants in the ACT group had significantly lower HAM-D scores at 1 month and then 3 months. Limitation here is they didn't have long-term follow-up, but it was an encouraging finding. They also showed that those subjects that had both mild and more significant strokes both showed a benefit from this. So we have some emerging data that suggests that psychotherapy can be effective. Again, methodologically, the studies tend to have a lot of weaknesses, but there's some encouraging data. Now, if we move over to exercise, so this is something I'll frequently talk to my patients about. So we know that if you look at exercise, we have good data showing that it can benefit cognition and it can also benefit mental health, in addition to all the other physical outcomes and health outcomes that you can see with people who are exercising regularly. So if you look at exercise in different modalities, so there are benefits across the board. So aerobics, probably the most frequently studied type of exercise activity, consistently has shown brain health benefits. When you look at resistance training, weight training, there's actually some interesting studies showing that BDNF is higher in patients that are individuals that are exercising with resistance. There's less consistent psychological improvements with resistance training. And then you have mind-body exercise. So think of yoga, for example. There's studies that have shown that improved attention, speed, and executive function, oftentimes that subcortical pattern of impairments that we see in stroke patients as well as depression, you can see benefit in those areas. We also know that depression and anxiety symptoms are improved. And so we know that exercise works. Now, as far as how to prescribe it, patients will frequently ask, well, what should I be doing? And I really fall back on the AHA guidelines. So generally speaking, 150 minutes a week of moderately intense exercise is the lower bound estimate, right? So about 20 to 30 minutes a day. Now, moderately intense aerobics would basically be a brisk walk. However, if you can get a patient to engage in more rigorous activity, they don't have to do as much, so 75 minutes a week, you can actually see some more enhanced benefits from that. Muscle training, studies have suggested 2 days a week of strength and conditioning training can also help. And when patients are encouraged to do resistance or weight training, encouraging them to work all the major muscle groups is recommended. The other thing that generally I state is try to limit how much sedentary behavior is recommended. And I know, there are limitations here. I also try to be realistic. If I have a patient who has never gone to the gym in their life, the idea of getting them into a gym to do a bunch of strength training is going to be challenging. And so, understanding the patient, what their background is, what their resources are. Obviously, with stroke populations, we have to consider things like motor and sensory impairments after stroke. We really want to think about an individualized approach when it comes to prescribing exercise. But generally speaking, we do know that exercise can be an important intervention as it applies to not only cognitive deficits after stroke, but also depression and anxiety. The other thing that I frequently will preach to patients is about social connectivity, right? We are social by nature. So when we talk about social connection, this is this subjective feeling of being close and connected to others. Social isolation is this objective lack of social contact, and loneliness is the subjective feeling of being isolated or alone. And what we know is that studies in people with high quality social networks tend to have better cognitive functioning, and they tend to have less anxiety and depression as they get older. We know that social connections promote a sense of well-being. It boosts mood. So again, socialization in a way can be its own effective treatment or preventative strategy for developing depression. In a study by Elayobi et al. In 2023, this was published in Stroke, they actually examined the relationship between social connection, depression, and instrumental activities of daily living. This was in a sample of about 900 patients who had incident stroke. This was pulled from the health and retirement studies. And what they found is that patients who had increased social connection and engagement had less limitations in their instrumental activities of daily living, and they had lower rates and less severe symptoms of depression. So again, social connectivity, it's not a formal psychotherapy per se, but it can be encouraged and serve as its own intervention. I like this slide a lot. It's not specific to stroke, but this is pulled from Vanetta Dotson's lab. Vanetta Dotson is a neuropsychologist in Atlanta who's done a lot of really interesting work looking at brain health in the aging brain, and really highlights this interrelationship between these factors that can all contribute to the lived experience and whether or not a person can stay independent and have good quality of life. So things like chronic stress, mood changes, sleep changes, cognitive impairment, structural and functional brain changes. All of these things are interacting with each other to then produce how we're functioning. And hopefully in the previous slides, you've seen that we have multiple points of intervention where we can possibly reduce the risk of having poor functionality long term. I think you can overlay this on our stroke population as well, because a lot of these factors are very common. And I'll end with showing you this slide. So this is also from Vanetta Dotson's lab. This is not specific to stroke, but it does summarize some of the neurobiological changes that we can see in late life depression. So for example, you can look at kind of structural brain metrics. So hippocampal volumes for people that are depressed in late life tend to be smaller. If you look at prefrontal volumes, and the thickness of the prefrontal cortex tends to be lower in late life depression. People with late life depression also tend to have higher volume of white matter lesions. If you look at functional integrity of the brain, it tends to be reduced in late life depression. There tends to be more inflammation in late life depression. Now, in this study, they actually initiated an exercise intervention and followed up with these folks. And what they found is that exercise, independent of other interventions, had the potential to pull these back up. So highlighting, we don't always need, structured psychotherapy or even antidepressants to show improvements in mood that then also translate to structural and functional abilities in the brain. All right, so in conclusion, post-stroke depression, relatively common. So generally speaking, 30%. We know that post-stroke depression can persist. It depends on multiple factors. The signs and symptoms are very heterogeneous. Proper screening and assessment is really critical here. So being mindful of what some of those criteria are from the DSM, how we're diagnosing depressive disorders is really important. Generally speaking, this is my impression, was but there is encouraging findings showing support for antidepressants, psychotherapy, and psychosocial interventions. However, we also have the option of using other health behaviors as an intervention, including things like proper sleep, exercise, and social connectivity. And with that, I will go ahead and stop.
Dr. Baughman, thank you so much for that comprehensive presentation. A very fascinating topic on what we understand, or what some of us in the clinical practice are maybe limited in fully understanding and comprehending, that stroke is not just a physical disabling condition when it's experienced to severe cases, but it can also be in a mental health state disabling to some of our patients that are trying to recover. I encourage, for those of you that are viewing this, if you have any questions for Dr. Baughman, please put them into the Q&A or the chat. I know that some of you are interested in getting copies of this slide. Dr. Baughman, I wonder, is there a way that you could potentially put in the chat your email address if you'd be willing to share a copy of your slides? We will make this, thank you, we will make this presentation available to all of our members on the members only link of our website for viewing purposes. And I see your email address is made available there. Please, I encourage you all to reach out to Dr. Baughman with regards to the slide presentation. A lot to unpack there. We do have only about 2 minutes. I don't want to hog up some of the questions, but I do want to say some of what your descriptive basic care that can be done minus pharmacological medication intervention, or perhaps the absence of cognitive therapy, is a lot of what we do teach in the general public when we do outreach about the importance of exercise, diet, and wellness, not just in the post-stroke phase, but also in the prevention phase. So that message will never change. I wonder, what are your thoughts on not only the evidence that we're limited on research at this time? You touched on the acceptance and commitment therapy as an example. For me, it triggered the thought of like mindfulness practice. What are your thoughts of mindfulness practice or meditation as being a possible antidote to relieve some of that anxiety or perseverating thought that can kind of impact recovery?
Yeah, so that's a fantastic question. In my answer, I will acknowledge a strong bias. I think mindfulness can be one of the most effective treatments or interventions for dealing with some of these mental health outcomes in stroke. We actually have a doctoral candidate here in Memphis who is in the Department of Nursing, who is doing her dissertation right now on a group based mindfulness intervention is some legitimate data showing that mindfulness can result in enhanced outcomes following stroke. I also, in my clinical practice, do see a lot of patients that have traumatic brain injury, and there's a plethora of studies in the TBI literature showing how mindfulness can be a useful intervention. And the other thing that I really like about mindfulness, I don't know, it's probably similar all around the country, but I know here locally, it's very challenging to get our patients into therapy. We have excessively long waiting lists. I might see a patient following stroke, and I might be catching them, 2, 4, 5, 6 weeks out of the stroke. And then I'm seeing some signs of depression. So the thought is, well, I'd like to get them into therapy. Frequently, we're running into 3, 4, 6 month waiting lists for psychotherapy from community psychologists or licensed professional counselors. And so it's challenging, even though we know there's some promise in psychotherapy or psychosocial interventions, just getting our patients there. So, psychotropics may be a better option because there's a more immediacy to it. But we also run into the fact that a lot of our patients are really reluctant to start on psychotropics. And so, one of the ways that not only mindfulness, but some of the other exercise and health behaviors is that usually they're, in my experience, so this is anecdotal, but a lot of patients find those a little bit more acceptable to do. And with mindfulness, we have a lot of applications now that are digitized where you can start right away. They're fairly simple. You don't need a high level of expertise to gain a benefit from mindfulness. Obviously, not everybody's going to be a Buddhist monk who has been doing mindfulness for years and years and is an expert. But even for novices like myself, there is still a benefit from doing these. And so I absolutely support and encourage, and we'll talk about mindfulness interventions and options with my patients.
Well, perhaps we can encourage you to maybe come back with a topic discussion on that. And we appreciate your time, and I want to thank the audience for their participation. Please look for correspondence from Arizona State University on the survey of Dr. Baughman's presentation. Dr. Baughman, if there is an upcoming lecture or area that you're going to be presenting in the near future, could you perhaps plug that if you have anything coming up or anything that we should know about you before we sign off?
Absolutely, I'm happy to. I don't have anything right now, but I will definitely keep you guys in mind.
All right. Well, thank you very much for your time, and I hope everyone has a great afternoon. Take care.
Thank you, everybody.